Hi, my name is Chris Campbell. I was asked to talk to you guys today about child welfare response to opioid, methamphetamine, and other substance use disorders in pregnancy. I think it's really important for everyone to understand someone's background, especially when we're talking about things like this. So, in introduction, I'm a child abuse pediatrician. I work at the University of Utah. I've been here since 2006. I'm really fortunate in that I get to work pretty closely with the Division of Child and Family Services as both a clinical consultant and a research collaborator. If we go back a few years before that, though, I was a pediatrician with the Indian Health Service on the Navajo Reservation between 1999 and 2004. And there I became, just by default, really, the child abuse expert, which is where I first became interested in these topics. And then we skip back a couple more years. I was a medical student in Baltimore in 1991 to 96. Right at the height of the AIDS epidemic, with IV drug use being the primary form of transmission at that point. And then if we go back way back, I come from a US white Southern family with background in Tennessee and Georgia. And I think these are really important things to understand because the lens with which we approach topics like substance use, child abuse, and child welfare involvement all involve who we are and what our expectations are. I also think it's really important to understand what I'm not. I'm not an expert in obstetrics, maternal fetal medicine, addiction medicine, neonatal medicine. I certainly think that you've got plenty of folks working with you on those topics. I'm not a lawyer. This is in no way legal advice. And I'm not a child welfare administrator or caseworker. I've never been one. And what I'd encourage you is, through some of the talk today and then through your own work, getting to know your local team, because collaborative work in these cases is really important. So let's say it's a Friday afternoon, you're in rural San Juan, you're working and a new patient has come in, and she's a 20-year-old woman who's late to enter into prenatal care. She's 21 weeks gestational age. And she talks to you a little bit and tells you that she was first ambivalent about this pregnancy, but now actually she's feeling pretty hopeful. She has a prior pregnancy. At age 18, she had minimal, almost none, really, prenatal care. She delivered a baby boy who had opioid withdrawal symptoms at birth. And because they couldn't establish a safe care for her, the child went into foster placement from the nursery and ultimately has been adopted out of that foster care placement after multiple relapses. At age 17, she really started having these problems with her substance use. Currently, she's on oxycodone, which is prescribed for chronic pain, but she does have a recent history of polysubstance abuse, including opioids, amphetamines, and benzodiazepines. And she reports to you that she's had inconsistent treatment history because of access, because of her environment, and just her lack of engagement. And then if you take that time and you step back even further in her history, you'll learn that at age 16, she was a driver in a multi-fatality motor vehicle collision. She dropped out of school soon after this. She has experienced complicated grief reactions and PTSD for years, and she has chronic pain and opioid dependence as a result. And so that woman presents for prenatal care, and she has a tremendous number of maternal risks that you can identify immediately. She's at risk for peripartum morbidities, for pain exacerbations, both during and after pregnancy, mental health crises, domestic violence perhaps, and certainly overdose and suicide. The infant, should it be born, may be at risk for birth defects because there's perhaps some risk of gastric schisis or congenital heart defects, certainly for preterm birth, for opioid dependence and withdrawal, and then potentially for abuse and neglect or maltreatment. Now, these are individual risks, but they are shared risks. And so both mother and child potentially share all of these risks, plus child welfare involvement, foster care placement, and termination of parental rights. But if you have the optimism on a Friday afternoon, when this woman presents for prenatal care, you can see that you have shared opportunities as well, because she is just 20 weeks estimated gestational age, which means you can take steps to get her into evidence-based OMSU treatment. You can get her into evidence-based trauma therapy. You can get the child, should they be born, appropriate and evidence-based treatment for withdrawal. And now you can start creating plans for safety and well-being that may make her history different this time than the last time she gave birth. And so the goals of care today and moving forward with her should be to reduce the risk of maternal mortality and morbidity, to optimize the outcomes for pregnancy and delivery, to build a cross-sector, comprehensive team that will support safety and health for her family, and for the infant that's delivered, the child who's growing up, and the adolescent that they become. The objectives of today's talk are to discuss a little bit about child risks after OMSU in pregnancy, and pushing you to see beyond neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, and to look at child maltreatment and child fatality risks for these kids. I want to talk a little bit about child welfare response to OMSU in pregnancy from both the federal perspective and the state level, in terms of the reporting requirements, plan of safe care guidelines, child welfare decision-making, and some of the outcomes associated with that. And finally, I want to adopt an ecological framework to look at how we collaborate for families who are affected by OMSU in pregnancy in order to build safety, health, and well-being for everyone involved. And so to talk a little bit about child risk after OMSU in pregnancy, what we know that's been described is that there's neonatal health risk, and those include obviously withdrawal, prematurity, growth retardation, and then again, some question of birth defects. There's also been discussion of longitudinal developmental risks, and that includes developmental delays, disruptive behaviors, attention deficit disorder, lower educational achievements, and criminality. But really, what we might have missed in some of the discussions or even the expectations of these types of outcomes for children is that what we know from literature that actually has come out of the University of Utah is that that literature on prenatal opioid exposure and the short-term impact actually seems to suggest that there's no effect. Findings from studies in which there's longer-term neurodevelopmental outcomes that are examined are mixed and may provide a little bit more support for an association with opioid use disorder, and there may be an increased risk for problems with attention, lower IQ, or poorer performance on academic testing for these kids. But the reality is that children who are born with prenatal opioid exposure and substance use of other sorts are more likely to be raised in poverty. And in many studies, exposure to poverty appears to drive most of the neurodevelopmental outcomes that are being observed, which led the authors of this paper to conclude that the state of the field has serious methodologic shortcomings, such that pediatricians and psychologists have scant evidence with which to answer their parents' questions. Specifically, how does opioid exposure affect my child? And those methodological shortcomings are critical because we made this mistake before. In the 80s and early 90s, the children who were born during the crack epidemic, particularly on the East Coast, were nicknamed crack kids. And they were viewed as children who were essentially a lost generation, damaged so much by prenatal drug exposure that they were destined to have tremendous neurological and behavioral problems. The myth of the crack kids presumed a prenatal determinism. And when there were observed infant and child difficulties, we relied on attribution bias and confirmation bias to prove that it was the crack cocaine exposure in utero that caused these problems. But over decades of research, years later, after the generation had become adults, really, we saw that there were actually minimal effects from the crack cocaine. And in the terminology of someone who was running for president at that time, it actually turned out to be the economy and the environment that led to most of the effects that we were seeing. And so instead, we should think about that environment and realize that that environment is similar and may be encouraging the risk factors that are associated with child maltreatment. And so we should be thinking about child maltreatment that's associated with caregiver, opioid, methamphetamine, and substance use disorders. Because we know from child welfare data in 2019, which is only the second year that they've collected this data at a national level, that almost 30% of substantiated child maltreatment investigations by Child Protective Services are associated with caregiver OMSU. Now, this isn't specific to pregnancy, but we still know that that exists. And similarly, substantiated child maltreatment fatalities, children who die as a result of abuse or neglect in 29 states, 1 out of 5 of those in 2019 are associated with caregiver OMSU. We also know that OMSU in pregnancy is associated with an increased risk of child welfare involvement. We know this based on a study of almost 500,000 children who were born in 2006 in the state of California. And in the first year of life, almost 30,000 of all of those children were reported to CPS. 12,000 were substantiated as victims of abuse by a CPS investigation. and almost 6,500 of those children spent some time in foster care as a result. Now, when we compare the children who were born with exposure, with known exposure to OMSU in pregnancy, to those who didn't have that same exposure, in an adjusted model, researchers found that almost 5.5 times higher rate of CPS referral for children with OMSU exposure history, 9 times higher rate of CPS substantiation of child maltreatment, and 11 times higher rate foster care placement for those children in that first year of life. So what that means is that you can look at the child in the nursery, and regardless of what we don't know, we do know that that risk of child welfare involvement, substantiation of child maltreatment, and foster care placement is higher for that child. We also finally know that there is a higher risk of severe physical abuse for children in the first 6 months of life if there is a history of OMSU exposure in pregnancy. A recent study of 3.75 million infants who were born in 2013 and 14 in 9 states in 1 year and 12 states in the next. They looked at children who had OMSU exposure in utero. There were about 33,000 of them. And then they looked at the 1,200 children who were hospitalized before 6 months of age for serious physical abuse. And what the researchers in this study found is that, or these studies found actually, that there was an almost 3 times higher risk associated with that history of OMSU in pregnancy, and an almost 4 times higher risk if the child had had neonatal abstinence syndrome or withdrawal at birth. Now, of course, there's other factors that compound the risk for child maltreatment after OMSU in pregnancy, and studies have shown that demographics such as poverty, rurality, are all associated with increased risk for child welfare involvement and child maltreatment with that history. Caregiver factors such as co-occurring mental illness, polysubstance use and abuse, and prior CPS involvement also predict CPS involvement, foster care placement, and victimization. And then child factors such as prematurity and low birth weight have also been shown to be associated. Now, this map that I'm showing you is interesting to me because I think it in a very nicely color-coded way, shows how there's been this relationship in some areas between increasing rates of overdose deaths and foster care placement. So what you'll see is the red counties across this map are places where we've seen both rises in overdose deaths, or we've seen high rates of overdose deaths and high rates of foster care placement. If you look at most of Utah, there's a few counties like that, but really the vast majority of counties in Utah have high rates of overdose death, but still in the lower range of foster care placement. And to be honest, that's because our child welfare agency has been for years quite committed to the idea of keeping families together. In looking at the state of Utah, though, I think it's important to recognize that San Juan County is actually an outlier for the state. While there's not been a relatively high rate of overdose deaths, at least on this map, the rates of foster care entry are high. And in fact, it's the only county like this in our state. I'm not sure of the reasons for that, but I suspect it has something to do with access to care and resources that are available. And so hopefully we can change that with time. Having said all of this, I think we also need to acknowledge that our data is severely limited around this. Because the reality is that when we're looking at the effects of pregnancy-related opioid use and substance use on children in a system outside of the medical or healthcare system, we require independent data sources to be linked across generations, bringing together maternal and infant child records, and across sectors that includes medical and child welfare records. And this is incredibly difficult. We also have interwoven cognitive biases because we have selection bias in that we know that we don't test women or seek out evidence for substance use in the same way or equitably across a population. We may not report equitably across a population. And we have confirmation bias because we may choose to accept evidence for substance use in some and not others because of expectations, and then we use only the evidence that confirms our bias. And finally, we have trouble with definitions that vary across individuals. My definition of substance use may be different than my colleagues, and across sectors between child welfare and child health care, for substance use, misuse, and addiction, for fetal exposure, and for child maltreatment. And because we are so siloed between practice types and across sectors, this leads to difficulty in knowing what's true and what's not true, what we're observing, and trusting our data. But so if we come back again to our Friday afternoon patient, we can see pretty quickly that this is a patient who's presenting with layers upon layers of risk. She's from a rural county. She's had opioid withdrawal and foster placement, that past history of CPS, and her prior child was adopted out of foster care after multiple relapses. She has that history of polysubstance use, which is another risk factor. She's dropped out of school, which makes us think that she's at risk for, if not living in poverty currently. And she's had complicated grief and PTSD with inconsistent treatment, which gives her that intercurrent mental illness that compounds the risk for child welfare involvement and child maltreatment. I want to touch briefly on child welfare response to opioid, methamphetamine, and substance use in pregnancy. First, I'd like to make it clear that during pregnancy, OMSU is not child maltreatment. One of my colleagues at Dcfs has made the comment to me that if there's no child maltreatment. And so during this time, I think we can legitimately suggest that the woman should be at the center of our decision making, and we should focus on how to strengthen the systems and the supports around her to reduce the chance of child maltreatment should the child be delivered. After birth, OMSU in pregnancy may not be child maltreatment. The child may even have withdrawal, may have NAS or NOWS, not the easiest way to enter the world, but a treatable medical condition. And so while we are trying to sort out what's best and how to approach the mother-child dyad, the mother-infant dyad with OMSU exposure in pregnancy, we can still be working to strengthen and build those systems around them. And at all times, during birth and after birth, OMSU exposure in pregnancy is an indicator of risk. And we know that it's an indicator of risk for a range of adverse childhood experiences: poverty, domestic violence, mental illness, and it includes child maltreatment. And the plan of safe care that's been proposed and then actually formalized in federal statute sets up a process so that we can identify the systems that will support the mother-child dyad moving forward. So if we go back and look at a brief history of federal child welfare legislation that starts at Child Protective Services and moves forward now to this plan of safe care, CAPTA, or the Child Abuse Prevention and Treatment Act, was first introduced and passed in 1974 and created what we're all familiar with now, which is the federal mandate for state child protective services, or CPS agencies, as well as the federal mandate for reporting of suspected maltreatment, which is defined at a state level. Utah has mandated reporting at a universal level, which means all of us are mandated reporters for suspected child maltreatment. The Keeping Children and Families Safe Act was an amendment to CAPTA in 2003 and first brought out the idea of this plan of safe care for prenatal exposure, at that point to illegal drugs, and emphasized the need to establish maternal health services, social services, parenting services, and substance abuse prevention and treatment counseling for women who struggled with drug use during pregnancy. And then also mandated infant referrals to state early intervention programs. Now that was back in 2003, but I'll tell you that not very many people were talking about these plans of safe care until 2016, when we had the passage of the Comprehensive Addiction and Recovery Act. This strengthened the plan of safe care. It removed the idea that the substances and the substance abuse had to be with illegal or illicit drugs. It emphasized an equally weighted infant and caregiver needs in the plan of safe care, and required that states monitor and report out the effectiveness of their plan of safe care referrals. Now this made it so the states actually had to respond to this, and they've been struggling through some of the details. We look at the federal language, which really just CARA required that states create programs that include the development of a plan of safe care for any infant born with and identified as being affected by substance use, withdrawal symptoms, or a fetal alcohol spectrum disorder to ensure safety and well-being of those infants. And the plan of safe care had to address the health and substance use disorder treatment needs of both the infant, the family, and the caregiver. Now the challenge is that there aren't clear definitions. These are all great ideas, but there aren't clear definitions for some things. The plan of safe care requires that we define affected by substance use, withdrawal symptoms. The plan of safe care process needs to be better defined in terms of who's responsible for that response, when should it be developed, what are the outcomes that should be tracked, and most difficult yet, how should it be monitored and or enforced? And finally, they talk about the plan of safe care as if it is an entity, as if it's a thing that you could touch. But they didn't provide any templates. So states have been working for the past few years to develop these in order to adequately address both infant and affected caregiver needs. So what has Utah's interpretation of definitions been? For plans of safe care, Utah has chosen to define infants affected by OMSU, including alcohol, as those who have OMSU detected by screening, such as history or social work screening at birth, testing, withdrawal symptoms in the infant, or fetal alcohol spectrum disorder diagnosis in the infant. It excludes, however, legally prescribed medication, including medications for opioid use disorder, SSRIs, or other psychotropics which can cause withdrawal symptoms, but have been legally prescribed and there's not evidence for use of other drugs. Additionally, it excludes marijuana in the absence of additional risk factors. Providers can always feel free, though, to notify Dcfs with concerns, even if they're not 100% sure whether it meets that definition. Dcfs goes through a process of determining whether a formal plan of safe care is required, but does not exclude the possibility that a provider could create a plan of safe care if needed for safety. Utah has defined the plan of safe care process to mean that the response at a prenatal time, during the prenatal time period, is from the Division of Substance Abuse and Mental Health, not from Dcfs. Any referral that is coming in about a woman who is pregnant using drugs will be referred from Dcfs to the Division of Substance Abuse and Mental Health to assure that she gets the treatment and care in pregnancy that is needed. The postnatal response, once the child's born, does come from Dcfs, and caseworkers evaluate the maternal and child safety, develop a plan of safe care to optimize health and well-being, and support as needed on the individual case with in-home services and community resources and collaboration. There's 3 different levels of outcome that will be determined by that Dcfs evaluation, and one is safe, which means that the family is safe even without a plan of safe care. Safe with a plan means that they're able to use the plan of safe care to identify resources and supports that will keep the family safely at home with child and parents together. And not safe is for those few cases in which there may need to be a separation of a child from a caregiver while that caregiver is obtaining needed care. The goal is always, from the perspective of Dcfs, reunification. Doesn't always work, but that's the hope that with appropriate care that can happen. Monitoring and enforcement is still not fully defined, and challenges, I would say, still exist. I think it requires time, trust, and collaboration. It's not always clear if someone is failing to follow up with a primary care pediatric provider who's supposed to be called, or who would make the decision that this is a violation of a plan of safe care. And the final statement I'll say is that the evidence for the effectiveness of this entire process is still under study and still needs to be better explored. Finally, we have a template, and Dcfs has been working on this template and has shared this draft with us. It'll be in the packet that you receive, and they'd like feedback on it. But I've seen this, and I've seen ones from other states. There's a lot of similarities. And what you'll notice is that it tries to formally establish who are the people in the household, who are the supports, what are the challenges, and what are the resources that can be provided. And it is signed in contract form. Now, there's no rule that this can only happen at the time that the child is born. In fact, many people suggest that these should be started in the prenatal period. And this brings us to the idea of cross-sector collaboration and applying an ecological framework to our understanding of how best to establish safety, health, and well-being over the course of a pregnancy and into that first year of a child's life. I draw from Bronfenbrenner's ecological model of health and human development, which was really created to explain how children grew up healthy in a community and an environment. And there is a microsystem around the children, which is composed of all of the individuals who care for that child. The exosystem, which are the systems such as healthcare, law, and child welfare, who inform and, in fact, may oversee the individuals within the microsystem. And that macrosystem then around them, which is the culture that defines the systems in place. Finally, there's a chronosystem, which is of a particular importance for children and pregnant women because so much changes over time. In thinking about this ecological model of health and human development and the systems that surround children as they're growing up, it's important, I think, to pause for a moment and think about the elephant that's stomping across the systems. And that's that we do have this history of discrimination, disparity, and disproportionality that affects our relationship with our patients in healthcare and our clients in child welfare. Some of you may remember a couple of years ago, this lovely article came out as the front page of the New York Times Magazine with this photo of a young woman and her beautiful infant, and she had had this child after a pregnancy affected by opioid use disorder. What was tweeted in response to the New York Times by some was what a contrast this was to the actual headlines that came out of the crack epidemic. Headlines like "Crack babies who are born to a life of suffering, crack's toll among babies, a joyless view. Crack's tiniest, even costliest victims, a time bomb in cocaine babies and a disaster in the making, crack babies start to grow up." This pervasive harm of the crack kid myth meant that we created a bio underclass. We had crack babies who were prenatally determined to be damaged. They grew into crack kids who terrorized our schools, and then as adults grew into what was eventually called a super predator. Even though if we'd waited, or if we thought about it, or if we'd seen the data and understood our biases, we would know that it was the environment that created this. That created a generation of lost trust that's divided across race and class, largely represented by the African American communities of the East Coast in particular, and stigma and shame for those who grew up with the label of crack kid. And as such, we have a generation of lost opportunities because we didn't look through a preventive lens, that preventive lens that could have said, let's shape the environment in ways that will help. And instead, we looked in the rearview mirror and saw this as a prenatal brand that these children had to hold on to. More recently, I think we remember that history of the Indian reservation schools or the boarding schools. What we see in the background here is the Carlisle Indian School in Pennsylvania. And in the foreground, what we see is a First Nations woman crying in front of a collection of shoes representing the thousands of children who have recently been discovered in graves of reservation schools up in Canada. And lest you think that this is something of the past or of another country, it's worth remembering that we're just now finding bodies of children in Panguitch, Utah, associated with one of the Indian reservation schools there. And so that history of forced separation and even cultural erasure of Native and Indigenous families in our own state and in our country is sort of there in the room, perhaps, when we're talking with families from that community who live within that macro system, because it contributes to the post-traumatic stress disorder, to the substance use disorders, and to the suicides that we see in those communities in excess of those from the majority culture. And it also undoubtedly informs the individual and community conversations related to substance use and alcoholism, to physical and sexual abuse, to parenting difficulties, and to child welfare involvement, because there is that history. And so as we start thinking about this from a systems perspective and from an ecological framework, it's important that we see that macro system, that we see the elephant in the room, or even just those pieces of the elephant that may be arising, and use that chronosystem, that change over time, to make sure that we're moving forward, that we're helping families move forward while still recognizing the impact of those histories. Because in the end, you're still here on a Friday afternoon with a woman who's presented for prenatal care. And we can see immediately that she has all of those risk factors, that she's from rural San Juan, that she's had all of the history of substance use and CPS involvement and mental illness. But then when we place her within the ecological framework, we can see that she, in fact, maybe that child that's at the center, because we know that people who experience trauma don't necessarily advance beyond those years. So she may be stuck as a 16-year-old in the center of these systems. And when we look at it that way, we can start seeing how we want to build the systems, and in that period of prenatal care, using that ecological framework to plan for her safety. And we do that by identifying her existing supports, because we know that suddenly she's become more hopeful and she actually came in for care. What made her come in, and where is she finding hope? We do want to go ahead and notify the Divisions of Substance Abuse and Mental Health, or Dcfs, because that's going to open up a landscape of DCFs resources that might not otherwise be available. And then maybe not today, maybe not this Friday afternoon, but maybe in subsequent visits, you want to start to talk about a shared plan of safe care that you can keep in her record, because that will allow you to monitor and keep both of you accountable. It's going to give transparency to your interactions. She doesn't have to feel like things are being hidden, and she's empowered to make choices understanding the repercussions. And then finally, you want to be engaging with her history. You want to acknowledge the loss of custody of that prior child and recognize and respond to that. You want to dig into that history of substance misuse and enroll her in an evidence-based OMSU treatment program, and you want to understand her complex grief and PTSD, and particularly during this vulnerable period, screen her for depression, suicidality, and refer her to evidence-based trauma care. Because eventually, in a couple of months, she's going to present to labor and delivery, and she's going to be a patient that's known to you. She's 21 now because she's had a birthday. She has had that late entry history, but she's had consistent follow-up since then because of the trust that you guys established. And she brings with her to labor and delivery multiple supports. She brings her mother and sister, she brings her pain management plan, and she brings her plan of safe care. You also know that she has history that's relevant to this delivery that's about to happen in terms of her substance use disorder. But now, instead of oxycodone and polysubstance use, she's on buprenorphine and doing well. You know she has that history of PTSD, and you've been unable to get her into evidence-based therapy because it's hard to do that. But she is managing her symptoms with the PTSD Coach app that you managed to download to her phone. And you know that she had this one prior pregnancy, and she has to be thinking about that because her child's been adopted and she's lost contact. She's anticipating, and she knows to expect Dcfs notification with this delivery, but this time she's ready. And so what we know then becomes important as she delivers and as Dcfs shows up at the hospital and she's referred back for care to her pain management team, is that what we need most acutely during this postpartum period is a strong mesosystem. And that's the cross-sector collaboration and the glue that sort of cements together a successful plan of safe care. It involves the medical team and all of the people, both for the mother and for the child. The mental health team, including the addiction medicine specialists, the therapists, and the other providers. It involves the child welfare team, and that involves the caseworkers and the supervisors, and then of course the family, the parents, the extended family, and the community who are helping this young family. So in the end, this time, she delivers a healthy baby girl. And I would say that given all of the skills that you develop through these courses, you get to write the end of this story because you're going to write it with that patient, you're going to write it with her family, and with her medical teams, with the mental health teams, and with her child. Because we want you to feel ready this time. And some of the resources that I've listed at the end here include, you can email me and we can have a conversation. Dcfs has also made it very clear that they'd love to have more engagement and involvement with the providers in their eastern region. And Robert Newman is the Dcfs administrator for that region, and this is his email. And then at the state level, Kyla Clark is a valued colleague of mine, and she runs the Strengthening Families program and is the one who supplied me with the Plan of Safe Care template, and would love to hear your feedback. I've included at the end practical guides that are helpful for folks who are trying to develop plans of safe care, but also for those of you who want to understand a little bit more about child welfare and substance use in pregnancy. This last one includes 8 research briefs, including one that focuses on the challenges in rural settings. And then finally, some selected research that I've used for this presentation and may inform some of your thoughts about child welfare involvement for these vulnerable families. Thank you very much. Please contact me with any questions.